Hello everyone. Here we are going to discuss a very important topic, that is sideroblastic anemia. So you usually get long as well as short question on this topic, especially on its pathogenesis, types and lab diagnosis. So let's start the topic. Here you can see we are starting it sideroblastic anemia. So if it is coming as a long question, you have to frame your answer under following headings. First of all, write down the introduction of the sideroblastic anemia. What is sideroblastic anemia? Define it, introduce it, then tell its pathogenesis. The most important, ultra important thing is the pathogenesis. You have to explain why does it occur in the form of the flowchart with diagrams. Then tell the types of the sideroblast. How many types of sideroblasts are there? You get a short or very short note on the types of the sideroblast. Then the types of the sideroblastic anemia. This is types of sideroblast. This is types of sideroblastic anemia. Then lab diagnosis, differential diagnosis and treatment. So you have to frame your answer of any anemia under these headings. All the anemia answer should be framed under these headings. So let's start it. Sideroblastic anemia. To understand the sideroblastic anemia introduction, you must understand normal iron metabolism. I assume you have watched my video on iron deficiency anemia. If you have not watched, please watch that also. You will have a better understanding here. So here I will help you in revising this concept again. The normal iron metabolism. We all eat iron in the diet. Either we eat in vegetarian diet or we eat in non-vegetarian diet. In the vegetarian diet, it is present in green leafy vegetables, in the jaggery. In the non-veg, it is present in the meat, red meat. So whatever iron we are taking, whether in veg or non-veg, the iron present in the diet is ferric form, Fe3 positive. So we eat Fe3 positive, that is known as ferric iron. It goes inside in the mouth, in the esophagus, in the stomach, and then it goes in the intestine. Then it goes in the cell of the intestine. So this is the intestinal cell we all can see. Here we all can see this is the intestinal cell. Can you appreciate this is intestinal cell? Now I want this iron to get absorbed and reach in the blood. I want this iron to get absorbed via this cell, the intestinal cell, the enterocyte, and reach in the blood. So we need two transporters, one transporter on the luminal side and one transporter on the basolateral side. The transporter on the luminal side is known as DMT, divalent metallic transporter. It takes the iron from the lumen of the intestine inside the cell, from the lumen to inside the cell. And the second transporter is ferroportin. Ferroportin take the iron from the lumen of the inside the cell into the blood. So we need two transporter, as you can see, but there is a problem. You will say, ma'am, what is the problem here? Let me show you what is the problem. Here you can see this is the cell. The problem is that this transporter DMT, what is the name? What is DMT? What is the full form of DMT? DMT is divalent metallic transporter. It transmits only divalent ions. That is, it will absorb Fe2 positive. It will not absorb Fe3 positive. The problem is that whatever we are eating in the diet is Fe3 positive, but for absorption purpose, we want Fe2 positive. So before absorption, we have to convert Fe3 positive to Fe2 positive. So who is doing this conversion? Who is doing this conversion? Who is converting Fe3 positive to Fe2 positive? So Fe3 positive to Fe2 positive, this is converted by HCl, the hydrochloric acid present in the stomach. The hydrochloric acid which is present in the stomach convert Fe3 positive to Fe2 positive. Now this Fe2 positive, it is converted into Fe2 positive, it will get absorbed. So via divalent metallic transporter, it will move from the lumen of the intestine into the cell, and ferroportin, which is the another transporter, it will transmit it. It will absorb it from inside the cell into the blood. But the ferroportin again will oxidize it. I mean, again the iron will convert from Fe2 positive to Fe3 positive. So whatever we eat is Fe3 positive. Whatever reach in the blood is Fe3 positive. Only for absorption purpose it convert into Fe2 positive. Okay, so these are the things you must remember. Now, here iron is Fe3 positive. Okay, ultimately. Now iron don't travel as it is in the blood. Iron need a transporter to travel it in the blood from here to there. The transporter of the iron, you can see this is the transporter of the iron. It is known as transferrin. Transferrin. Transferrin is the iron transporter. So can you see this is transferrin. So transferrin transmit iron. It transmits iron here and there. It travels the iron to the transporter. On one, I call it a scooter. You know, on a scooter, two people can sit. So on one transferrin, two iron molecules are there. You can draw two iron molecules. So it is the scooter. It is the car. It is the transporter of the iron. So where is iron required in the body? Iron is required only at one place in the body for heme synthesis. The heme of hemoglobin. Hemoglobin contain heme. Hemoglobin contains heme, and the heme is made up of iron. So iron is required for heme synthesis of the hemoglobin. Where is hemoglobin synthesized? RBCs are synthesized in the bone marrow, and RBC precursor have the hemoglobin. You know how does RBC get synthesized? So in the bone marrow, you can see the various stages of RBCs, the precursors of the RBC. So hematopoietic stem cell, myeloblast, pro-normoblast, early normoblast, intermediate normoblast, late normoblast, finally retic. So here the